Very good. Great. Well, I guess maybe I'll open. Welcome everybody to this great presentation by Dr. James Dunn on the intestinal lengthening for short bowel syndrome. I'm Andre Bissett, CEO and co-founder of Eclipse Regenesis. We are helping to bring this concept from the lab to the clinic. And today's episode is a private invite Zoom session. So there'll be discussion and question and answers at the end. And this will be recorded and made available to those that need it. So welcome, Dr. Dunn. Thank you so much. I'll turn it over to you.
Great. Thanks, Andre. Welcome. We will go over some basic concepts as well as what we have done in the clinical setting with our device called Eclipse XL1. It applies the principle of distraction enterogenesis, which is a way to apply force to the intestine to allow it to grow, and that this actually has the use to reduce the need for TPN or Gattex for patients with short gut syndrome. The basic idea is illustrated in this panel of slides here. On the upper left-hand side is a patient with short gut syndrome, and the device, the XL1 device, is inserted through an opening made in the intestine, as a picture here. And then the device is then held in place by plicating the intestine on either ends of the spring so that it is got something to resist the expanding spring. The spring is made out of nitinol material, and that in a compressed state, you'll naturally want to expand. And when it does, it initially stretches the intestine, but that mechanical stretch induces growth of the intestine, so that in a matter of a few weeks, the intestine grows in length. And this we have documented in many animal studies. And because the spring is hollow, it is able to allow the passage of enteric contents through so that there is no problem in terms of feeding during that time. And then ultimately, the device will be released once the absorbable sutures that were used to hold the spring in place have disappeared, and that we ended up with then new tissue. So after many years of work in animals, as well as going through the hurdles of regulatory process, the FDA allowed us to do this in a patient. And they had insisted that adults first. So our first patient is a 36-year-old man who have enterocutaneous fistula after multiple surgeries related to trauma. He had a little over 100 centimeters of small bowel and descending colon, and that's illustrated on this diagram here. And he was on TPN before the surgery. So at the time of his surgery to take down the enterocutaneous fistula, we decided that he would be a good candidate to put the spring in a segment of the small intestine so that it will lengthen the intestine at the same time. So a 19-millimeter device. So because the intestine have different diameters, we have different sizes, and a 19-millimeter device was then placed in the distal small bowel, and that's illustrated here. In blue is the spring, and then the plicating sutures either side of the spring. And then we took an X-ray right afterwards. You can see that in the right upper quadrant is where this spring is seen on the X-ray, and it is in a compressed state. And then with time, this is a week later, you can see that the spring has expanded. And then after 3 weeks or so, it's now fully expanded. And then the patient did well. No complications were noted related to the spring. And then he was sent home. He was able to eat and came off of TPN. After 2 months, the spring passed spontaneously, and that he is currently doing well. And this was done in 2023, so it's been over 2 years now, and he continues to do well. And with that, the clinical trial continue, and then a second adult patient was done about, I think, 8 months after the first one. And this patient also has enterogenesis fistula, but from a different cause of diverticulitis. But similar in anatomy, he has a little bit more colon than the first patient, but the anatomy is illustrated on the diagram, and that everything was in continuity except he has enterogenesis fistula, which requires surgery. So as surgery, his intestine is a little smaller, small intestine is a little smaller, so we were able to place a 14-millimeter device in the ileum, and that's illustrated on the diagram here again in blue as the XL1 device. And then again, immediately afterwards, we got an X-ray. You can see it's also on the right side of the abdomen for this patient. The spring is in a compressed state. And then a week later, it's a little harder to see just because of the playing of the X-ray, but you can see that the spring continues to be on the right side of the abdomen. And then by day 16, with a little bit more movement, you can see that the spring has expanded. This patient too did well after surgery, was able to tolerate a regular diet afterwards, and not on TPN. And then in just about 18 days, so not quite 3 weeks, the spring passed spontaneously through the colon and out the rectum. And I forgot to mention this, but the first patient actually didn't even know that he passed the spring. It was just not seen on X-ray, so presumably it got covered up with the stool. But the second patient noticed the spring in the stools, and we were able to recover that spring, and that spring is completely intact. So he's also done well. He's about 1.5 years or so out from this procedure and continues to do well. With this experience in the adult patients, the FDA then allowed us to start to do some pediatric patients, which of course is what I would always intend the device for, although it can be used obviously for adults and children. But because of FDA's concern, we had to do these adults first. And with that, they weren't quite ready to have us do a formal clinical trial with pediatric patients at the time, but we were able to apply for a compassionate use pathway. So not in the trial, but on a case-per-case basis, they would allow us to do this study in the pediatric patient. So this led us to the first pediatric patient, and this is a 2-year-old who had necrotizing enterocolitis as an infant. He ended up with 4 meters that was anastomosed to the colon. He had a little bit of an ileal stump left, about 1 centimeter at the time of initial surgery, that I thought was too short to do a safe anastomosis, and therefore the jejunum was plugged into the colon. And this little ileal stump I left behind, thinking that it may grow and may be of use later on. And although 40 centimeters is a reasonable amount, it's sort of on the border of not being able to come off of TPN, and he continued to require about 50% of his calories from TPN after 2 years. He's tolerated some enteral feeding. He was started on Gat-Tex, but continues to have fairly loose stools, 4 stools per day. And with that, the idea that we applied to the FDA for compassionate use was to try to put the device into this ileal stump so that we can make that stump longer. And the idea is that once the stump has grown to be of significant length, then we can reattach it into the continuity of the small intestine to help with absorption. And we all know how important ileum is in these patients with short gut syndrome. So with these rationale, the FDA allowed us to proceed with placement of the spring device, and that we were able to do so. This ileum, as you can imagine, is smaller because of the pediatric patient and the fact that it is not in continuity or direct continuity, I should say, with the enteral stream. So anyways, an 11 millimeter was devised, and at that time, that little stump had grown a little bit to be 2 centimeters, which is really the minimum length that we need to put in this device. So that was done, as illustrated here. Again, the spring was placed inside this little stump, and then we followed it with X-ray. You can see the immediate X-ray after the procedure, the compressed spring, which is now in the right lower part of the abdomen in a compressed state. And then with time, a week later, the spring has gotten to be longer. And then that spring continued to be in the same place. And what we have noted is that the stools for this patient had become more solid. That's one of the remarkable things that happened. And the stool was much more solid compared to before with the enteral feeding. So that's something that appears to be a repeatable thing, as we'll see a little later. And even though we did not restore that piece of ileum into continuity as we had planned, he was able to wean off of TPN in 3 months because as the stool became more solid, the intestinal rehab team that's managing him was able to increase his enteral intake, mostly through the G-tube because he does have some oral aversion. And nevertheless, they had increased it to fully support him, with him continuing to gain weight throughout this period of time. And he came off of TPN. But the spring in this patient, and that appears to be a theme for the pediatric patient that we have done so far, did not pass. So even up to 3 months of time, when he came off of TPN, the spring was still in the same place. So this suggests that there may be some systemic effect that happens with this mechanical enterogenesis process, even though the ileum is a little bit longer, but it seems that the rest of the GI tract has better absorption even before we restore that into continuity. But anyways, we then had to do a surgical procedure to remove the spring because we didn't want to leave it in for an indefinite period of time. So the spring was removed, but he continues to do well, and that he continues to be off of TPN. And this is a picture of a very first patient with the parents, and they were very excited about all the things that have happened for their son. And then we were able to continue to do compassionate use on pediatric patients. And then our second pediatric patient is a little younger patient, 1.5-year-old at the time, who had necrotizing enterocolitis. And this patient is ultra short. This patient only has about 6 centimeters of ileum, 2 of which is the jejunum and 4 ileum. He was on mostly parenteral nutrition with just a little bit of enteral feeding each day. So it is very unlikely for this patient to come off of TPN in many, many years. And with that rationale, we applied to the FDA for compassionate use, and they allowed us to move forward with this patient. His intestine is a little bit bigger. 14 millimeter device was placed in the ileum, as illustrated there. And then that again, X-rays immediately afterwards, you can see that the spring is in a compressed state, and then the spring expanded, and 2 months later, it continues to be in the same place. This patient, unfortunately, developed RSV pneumonia and got quite sick and had to be in ICU. So we did not want to intervene on the spring during this time of illness. and he stayed in the hospital for almost 2 months, I think, for this bad pneumonia. And then, however, he was able to tolerate more feeding, so his amount of enteral feeding increased, his number of stools decreased, and he continues to gain weight despite these other medical problems that he had. So eventually he recovered from all of that, and at 6 months of time after our initial spring was placed, we removed it, and that the ileum had grown a little bit, as illustrated here. We did the operation 200 days later, and that's probably a little bit too long. I think that ideally we would do the spring procedure a little sooner to replace the spring so that you can continue to expand that segment. So this is the second pediatric patient, but the first who received a repeat spring to make that segment even longer. And this is what we found intraoperatively compared to the picture of how this looked like initially. And here's the charting on how this patient did in terms of the amount of parenteral nutrition. He still requires mostly parenteral nutrition, even though we're able to increase the enteral feeding. The amount of length gain is relatively small compared to what he really needs to be able to come off of parenteral nutrition. But nevertheless, it did well, continued to gain weight, and that currently he has that second spring in place. He, however, continues to have other problems. He recently got admitted with another pneumonia from different virus as well as central line infection. So that's sort of the update on him. And then the third pediatric patient is a 1-year-old, so a little younger still, but her problem is volvulus, and she ended up with 20 centimeters of jejunum that's attached to the colon. She, like the first patient, also has a little bit of a ileal stump left. But because of the shorter amount of bowel, she was on much more parenteral nutrition compared to the first patient. And that we, again, used the same rationale to try to lengthen that residual piece of ileum, much like the first patient, and apply for compassionate use, which the FDA had permitted. And she had a 10 millimeter spring device placed in the ileal stump. And then after that grew to be a little bit longer, we replaced it with a 14 millimeter device 4 months afterwards. And these are some of the x-rays, so similar to what we found, compressed spring, and then a couple months later, it's gotten longer. And this is the various nutritional assessments of that third patient. Again, still requiring a fair amount of parenteral nutrition. This patient did not have the remarkable response like our first patient had, but it's not really anticipated because we have not really restored the piece of ileum back into continuity, and that our plan now is to potentially insert a third spring, depending on what the state of the ileo remnant is. On X-ray, it looks like it has grown to be about 4 centimeters or so. So we might be able to just restore that into continuity and see how she does. With all of that, we again went back to the FDA, and then this time we were able to convince them to now extend the trial into pediatric patients. So they no longer require this compassionate use pathway, and that our very first pediatric patient was enrolled from Cincinnati Children's Hospital. And this is a 1-year-old child with necrotizing enterocolitis, has had a lot of difficulty with feeding problems, and Dr. Helmrath at Cincinnati Children's is the investigator there, and he has a practice where he would bring stomas up for these patients and put in a feeding tube into the distal intestine. So this patient had 56 centimeters of proximal intestine, but 13 centimeters of intestine separated from continuity, but has a feeding tube through it so that he can continue to feed distally. And then at the same time as that, at that operation, a 10 millimeter XL1 device was placed in that segment. And you can see that on the X-ray. There's the spring on the right side of the patient, and then there's a feeding tube that goes through it. And then again, with time, the spring has expanded in length, and the patient is able to wean, not completely off of TPM, but some PM was able to be weaned for the first time for this patient. This patient continues to do well, and at some point, Dr. Hamrath will remove the spring and restore the patient's intestinal continuity. So there are more adults that were done in the trial, and our experience with the device placement is summarized on this table here. A total of 9 procedures have been done. Some of the patients, as have discussed, have had repeated springs placed. Some were in the trial, others in the compassionate use pathway. But so far, we have not experienced any complications related to the device. And some of these patients have actually weaned off of TPN, as summarized here. So in adult patients, these springs seem to be able to pass spontaneously. That seems to be not the case for the pediatric patients, but for these pediatric patients, we have gone back to replace the spring or to remove the spring as indicated. In total, 4 out of the 6 patients are no longer on parenteral nutrition. And as I alluded to earlier, there may be a systemic effect that's produced by this process of distraction enterogenesis. So this is the current state of the study sites. We have Boston Children's and Cincinnati Children's who are approved and ready to enroll patients. And then these other sites are in the works in terms of getting into the trial. But it is also possible for them to do patients outside the trial in the compassionate use pathway. With that, I'd like to thank all the people who have worked on this. This is quite a project that expanded over a couple of decades from the basic laboratory to clinical application, and with the support of a lot of organizations as listed. That concludes my presentation. I'd be happy to take any questions.
Good morning, Dr. Dunn.
Good morning.
Morning. I'm Tom Lin. I'm an interventional pediatric gastroenterologist over at Rady Children's in San Diego. And a couple of questions. One thing is, for the pediatric patients, any theory behind why they didn't necessarily spontaneously pass the spring? Was there any type of tissue ingrowth? And if not, is there a thought of removing it endoscopically rather than having a second procedure, especially if there was not a plan to place a second spring?
Yes, I think that all those things that you said have some component of it. For some of these pediatric patients, I think that, for example, when I place the spring in the ileal stump, there's really no motility in that little stump to be able to push it forward. So that is probably part of it. And then the other part of it is with time, like I mentioned, for some of these patients where we left it in for several months, there was tissue ingrowth. So it was holding it in place. The first pediatric patient, we actually did try to remove it endoscopically because part of it had passed into the colon. So half of it was in the colon, half of it was in the ileal stump, but the endoscope was not able to extract it because of the tissue ingrowth. So surgical removal was necessary to do. So I think going forward, definitely we don't want to leave these devices in for a prolonged period of time.
Okay. My second question is, if there is adequate length of the small bowel, are there thoughts of in the future placing more than one spring device at the initial index surgery?
Absolutely. That is sort of the goal, and we've demonstrated in animal models that it is feasible to have multiple devices to lengthen the bowel simultaneously. This, of course, is not what the FDA wants us to do at first. They wanted us to do one device at a time. But in our most recent revised discussion with the FDA, they now have allowed us to put in 2 devices at the same time. So hopefully that will lead the way to having even more than that in the future.
Great. One last question, sorry. The spring device itself, is there a anticipation of developing where it can be deployed and maybe fixed in place endoscopically rather than a surgical
Absolutely.
approach?
We're on the same page. The company is in the process of doing just that, to be able to develop a way to deliver the device endoscopically. The challenge is how to fix it in place, because if you try to place sutures like we did with the open technique, it's very hard to do so endoluminally. So the company is working on a way to fix the spring in an endoscopic fashion.
Thank you.
Dr. Dunn, I had a question. Patrick Javits from Seattle Children's. In some of our patients, their remnant small bowel, especially if it's already in continuity, dilates significantly. Have you seen bowel in kids or in your animal models where the bowel is too dilated to kind of hold the spring in place to get the lengthening that you're aiming for?
Yes, we have. I did not include that in the series of patients we have presented, but we have attempted placing springs in a couple of kids who have relatively dilated intestine, and that they were not able to be held in place. So yes, currently our device goes up to 2 centimeters in diameter. So if it's dilated beyond that, the device currently will not be able to be used for these patients. So we are in the process of trying to get devices that are bigger. So it is fairly important that the intestine or the spring fits inside the intestine reasonably well. Otherwise, because of the extra room, the spring can rotate and gets squeezed out of the plication type sutures.
Okay, thank you.
All right. If there are no other questions, Andre, any last remarks?
No, James, thank you so much. Dr. Dunn, that's a great summary and presentation. Dr. Javits and Dr. Lin, thanks for the questions. Just in terms of next steps, right now the study is open at both Boston and Cincinnati Children's. Some people have been actively referring patients there. We're also in the process of opening up the study at additional sites. And we also have the ability, even at your sites, to be able to do compassionate use. And again, we would work with you to get that process done and get the permissions through the FDA. We've been very successful doing that as a quicker way to go versus becoming a full study site, which does take some time, typically, 9 months of IRB contracting and budgeting to get through the process, but happy to start that, consider that, and work with you guys also if that's of interest. So we're excited to finally be at the stage where the study is open and enrolling, and excited to start to bring this to these patients across the country. And with that, if there's no other further questions, we'll bring it to a conclusion. Appreciate everyone's time today. All the best, and we'll talk to everybody soon.
Thank you, everybody. Thank you.
Thanks.
Thank you, guys. Thank you.